Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Thanks, Brian. Thank you, everyone. So yes, as Brian said, this is the first part of reviewing the 2020 HIV Medical Association's Primary Care Guidance, which came out in early November. I have no conflicts of interest or relationships to disclose, and I just wanted to share the previous primary care guidelines, which were in 2013, also made by the HIV Medical Association, and this is what it looks like. And then this is the updated 2020 primary care guidance. I think we've probably all used the 2013 ones, and I'm sure a lot of us were waiting for these 2020 ones, which finally came. I think we had initially anticipated them earlier in the year, but not surprisingly with COVID, things got pushed back. And so this was shared in early November, as I mentioned earlier. What is new in the 2020 guidance as compared to the 2013 update? First off, it starts using people first language, which is really nice. There's a new section on transgender and gender diverse populations, a new and brief section on COVID-19 and people with HIV, which is obviously ever-changing. It incorporates the concept of U equals U, or undetectable equals untransmittable. And lastly, it mentions telehealth as an option, and that was not there in the 2013 guidelines. So those are some of the big changes. And I just wanted to sort of let you know that this is how they broke up the sections. This is a hefty document. It's approximately 33 pages of text, not including the resources, and it's broken up into these 9 sections. Optimizing care engagement, medication adherence, and viral suppression. Then it talks about the initial evaluation of people with HIV, and then routine healthcare maintenance considerations, metabolic and other comorbidities. And then sections 5 through 9 are special considerations for certain populations such as cisgender women and transgender men of childbearing potential, children, adolescents, transgender and gender diverse populations, and then lastly, as I mentioned, it touches on COVID-19. So because this is a very big document, we only have time to talk about these 4 top sections over the next 2 echo sessions. So as I mentioned, today we're going to comment first on sections 1 and 2. This part will be a bit briefer than next week, which is a bit more substantive, which is reviewing the healthcare maintenance and metabolic complications. And so with that, I also wanted to share what I'm hoping to accomplish in the next 15 minutes or so. So this is really tough to do in 15 or 20 minutes. As I mentioned, it's 33 pages. There are 96 recommendations, and it's just hard to distill into 2 small sessions. I think also what's difficult is that there's not much out there about evidence-based practices to teach guidelines or how best to review guidelines. And so what I'm hoping that we can do today is basically that I would hope to familiarize you with the 2020 PC guidance, to sort of highlight some key tables that you can use as resources and show some of them so that you become comfortable with using these guidelines, to remind the ECHO community about certain practice recommendations, which will hopefully be practice affirming, discuss a few areas where practice patterns may vary, and we'll do this more in next week's session and a little bit in this week's session. And I'd like to encourage reflection on how the guidelines may change your practice. So really thinking, is this something that I'm going to keep doing? Is this something that I'm going to change? Or just how do I feel about these guidelines and recommendations in general? And so I really like to encourage that during today's talk. And some reflections that I had about these guidelines I'd like to share. So first, I really appreciate that they sort of focus on people first language and that they have a holistic approach. One thing that I did notice, but there are a lot of typos and a lot of sort of mistakes with regards to citation. So that is something that was noticed. And I think also too, it tries to tackle a lot, and perhaps that's too hard to do in just one document. So those are some observations and reflections I had about the guidelines in general. So with that in mind, I'm going to try to distill them as much as possible into just a couple of minutes. So first, the first section was only a couple of pages, and that was about optimizing care engagement, medication adherence, and viral suppression. It had 4 recommendations. First was that all people with HIV should have timely access to routine and urgent primary medical care, including considerations for extended or weekend hours or telehealth, to provide care in a way that is linguistically and culturally appropriate, that HIV care should use a multidisciplinary model but identify a primary clinician for each patient, and that patients should be started on ART on the day of diagnosis or as soon thereafter as feasible. I just wanted to highlight these 4 recommendations, not to spend too much time on it, but that some of these are really nice reminders for us about how we should be setting up clinics, how we should be interfacing with patients. And there's this one sentence that I wanted to share with you all in the evidence-based summary, or the paragraph section of the guidelines. And this is with regard to how best to engage and retain patients in care. It states a broad range of components, from having staff of the same race, culture, or lifestyle, to having art and reading material in the clinic that reflects the culture of the local community, may be useful in facilitating this goal. So as I mentioned, there are some holistic things that weren't present in the previous guideline that are in this one. And I really like that. So moving on from this brief section is to the initial evaluation and immediate follow-up for people with HIV. So this is a bit of a heftier section. It comprises recommendations number 5 through 45, and really begins with recommendations for the initial assessment of seeing a patient, for how to take a history, what review of systems to take, and the components of a physical examination that should be obtained when you're first meeting a patient. And I just want to show some of these tables, not to spend time on them, but so that you can familiarize yourself with what they look like. But the first table is what should be in the HPI. This is only a small snippet of a very large table. What other medical and surgical history you should be asking about when you first meet a patient. The initial assessment, including the review of systems and the physical exam. And lastly, the recommended initial laboratory screen. We're going to talk about Table 4 in a little bit, but I just wanted to highlight that I think some of these tables are good refreshers, are good sort of resources to use for teaching, especially with trainees. And then I think also are good, not just refreshers on what we should be doing or how we should think about what we're doing, but also about what to do in the time of. So you can say like, oh, what should I do in this section? And it can be used as a resource, as opposed to reading all 33 pages, which you certainly can do if you've got the time. So I wanted to talk about the initial lab assessment. This is something that Brian and I sort of adjusted from their large Table 4, which comprises 2 separate pages. And we sort of tried to divide this up into routine labs that you should be getting only in certain scenarios, and in a couple of areas for discussion, which we will discuss. So quickly, just to go through them, they recommend that at first you should get an HIV antigen antibody level, a CD4 cell count, an HIV viral load, a CBC, a CMP, a syphilis screen, trichomonas and GCCT screening to do STI screening, a viral hepatitis screen, and to look for latent TB infection, or also just screen in general for active TB. In certain scenarios, it recommends that you could consider getting a Trofile, an HLA-B5701 level, if you plan on using an abacavir-containing regimen, to screen for varicella or measles immunity, to get a cryptococcal antigen, to do a cervical pap, or get a pregnancy test. Again, these are only in certain scenarios. And there are some areas for discussion that some of which we'll review today and some of which I'm going to table till next week, because I think they fit a little bit better in the healthcare maintenance lab section. But those areas for discussion are sort of, getting a resistance assay when you first meet the patient, a lipid profile, a hemoglobin A1C, a urinalysis, a G6PD level, and an anal pap. They also specifically recommend against routine testing of HSV, CMV, and Toxoplasma IgG levels. So this is, again, this giant lab table, their Table 4, which we have tried to distill into these sections. And I'd like to give a couple of reminders, as we sort of mentioned we'd outline earlier today. And so the reminders that I'd like to sort of mention are about the antigen antibody, trichomonas screening, measles immunity, and a resistance assay. So the reminder for the HIV antigen antibody is that for patients who have no documentation of their HIV status or who were tested anonymously should have an HIV antigen antibody screening test performed upon initiation of care. I think most of us are doing this, but I think sometimes we might forget that we just actually do need to verify an antigen antibody level. Why is this important? I wanted to share an anecdote of when I was in residency and I had a patient move from California. They were on Stribild. They needed their Stribild refilled so they wouldn't miss any doses. They'd been virologically suppressed. So I refilled this patient's Stribild. I got a viral load, which was not surprisingly undetectable, and I sent this person on their way. A few weeks later, I get a phone call from public health saying, hey, Jehan, we actually don't have any documentation that this person has HIV at all. And so I remember when I was a resident, David Spock was my attending this day, and I needed some counseling on how to approach this patient that we thought that they did not have HIV. And I told them, and I think they had a conversion disorder because they seemed to still think that they had HIV despite getting an HIV antigen antibody test, which was negative. And perhaps this person just moved from state to state. That's an outlier. That is really rare. But I did want to share that, I think about this patient whenever somebody's coming to clinic for the first time. And it helps remind me that I should get an HIV antigen antibody level, just again, so that we have documented and also helpful for public health. Any comments on that before I move on to the next reminder? So the next thing I wanted to remind people about is about trichomonas screening. So again, all persons who have receptive vaginal sex should be screened for trichomoniasis at entry into care. They further continue, as you'll see the ellipsis, that if that person screens positive, that you should treat them. The recommended treatment for trichomoniasis in people with HIV is metronidazole 500 milligrams BID for a week, which is different than in people who do not have HIV. And the recommendation is that they should come back in 3 months to get screening since reinfection rates are high. The reason why I wanted to remind this or put this reminder in for the community here for this talk is that I think for a lot of us, perhaps we have mostly men in our practice. And I just wanted to sort of recall or just give this reminder for some of the patients who have receptive vaginal sex that we should not be forgetting about this in the STI screen. I think we get so used to GCCT and syphilis that sometimes we forgot trichomoniasis, or at least I do. And so I wanted to put this reminder in for everybody to make sure that we're getting this upon entry into care. And then the third reminder I wanted to sort of mention from the guidelines is about measles immunity. So they recommend that all persons with HIV born in 1957 and after should be tested for immunity to measles, mumps, and rubella by measuring antibodies. Now, I think the reason why I wanted to include this is twofold, or threefold actually. One is we have seen recent measles outbreaks in the United States of late as people are not being vaccinated as frequently. And then also in COVID, we know that COVID has definitely disrupted childhood vaccines and perhaps some adult vaccines. And so this is something that we may see the fallout from a little bit later. And then the other reason why I wanted to include this is that in October in OFID, or Open Form Infectious Diseases, there was an article which was a cross-sectional study of people at an academic HIV clinic in Omaha. And they looked at, I believe it was like 351 people with HIV, and they checked a measles IgG in everybody of that 351 group of individuals. And only 70% had measles immunity. So that was a lot lower than the authors expected. I think that's a lot lower than any of us would have expected when we really need something greater to like closer to 95% for herd immunity. So since this has been found in, again, this is one cohort in Omaha, but for the other reasons I also outlined, I just wanted to give this reminder that this is something that I have been more vigilant about since reading that article in OFID and something that we should be doing because it's in the guidelines. Any comments on measles or trichomonas before I move on? Okay, and then last of the reminders is HIV resistance testing. So it states that patients should be assessed for transmitted drug resistance with a genotype assay for PI, NNRTI, and NRTI mutations upon initiation of care. This is definitely something that I'm doing, is getting a baseline genotype. But I'm only doing it for, again, the sort of regular genotype. I am not getting baseline INSTI genotyping. And they state that if transmitted integrase strand transfer inhibitor resistance is suspected, that genotypic testing for INSTI resistance should be obtained. This is a whole talk that we could have in and of itself. We could spend greater than 20 minutes discussing the merits of getting baseline resistance testing or not. I think some people might argue that it's not really cost effective, especially in the era of using these very potent second generation INSTIs. And so that's one thing. But I did just want to mention that the HIVMA does recommend getting baseline genotypic testing for RT or reverse transcriptase and protease inhibitor mutations, but not to get it for INSTI resistance. There's one sentence that they said that we should consider getting INSTI resistance or an INSTI genotype in patients with evidence of transmitted drug resistance to reverse transcriptase or to protease inhibitors, or if acquired HIV from an individual on an INSTI-based regimen. So I definitely think about getting INSTI resistance an assay if someone perhaps might have INSTI resistance. What I sort of use my gestalt to decide upon that. But I thought it was interesting that they said that we should also be considering in people who have RT or PI mutations. I can't say that once I've found transmitted drug resistance that I've ever had somebody come back in and then subsequently follow it with an INSTI genotype. So I just wanted to mention that that's in there. See if people had thoughts. And I think just mention that I think that as we're using more and more INSTIs, I wonder how this will change or not change. And again, recognizing it's hard to bite off this topic, and perhaps we're not going to bite it off, but I just wanted to just mention this as a reminder. See if anybody had any thoughts. Good, because again, we could talk about this for hours. Okay. So then the last part that I wanted to finish up on was the sort of areas of discussion, or at least to sort of see how people are practicing in this community. So I wanted us to talk about next cryptococcal antigen screening and G6PD levels in somebody for initial labs. So here's our first audience poll question. And I wanted to ask, in which asymptomatic individuals do you check a serum cryptococcal antigen? In people with HIV with a CD4 cell count less than 50, those with a CD4 count less than 100, less than 200, or that you do not routinely check a serum cryptococcal antigen. Okay, great. So we had a pretty decent spread. 30% of individuals check it with a CD4 count less than 50, 27% check it with a CD4 count less than 100, and 42% do not routinely check a serum cryptococcal antigen. These are all correct. This is not meant to be a knowledge base. This is just meant to see what are people doing. And I wanted to share what the guidelines recommend. Again, recommendation number 45 states that testing for serum cryptococcal antigen may be considered in persons with a CD4 cell count less than 100 or in symptomatic patients. Again, the question I had specifically asked was in asymptomatic patients. I think if someone's symptomatic or we have concern about cryptococcal meningitis or cryptococcal pneumonia, we'd be more likely to get a CRAG. But really the question is about in asymptomatic individuals. Now, to the group of people that said less than 50, the DHHS guidelines also state that some experts recommend checking an asymptomatic cryptococcal antigen with a CD4 count less than 100, and then they say particularly in individuals with a CD4 count less than 50. And there is some data to suggest why this is done. There's data from an American cohort, from the MAX cohort and from the WISE cohort of approximately 1,800 individuals where they looked at their serum and then looked to see if they have a cragemia. And of that cohort, people with a CD4 count less than 50, 4% of individuals had a serum CRAG that was positive. And in individuals between 50 to 100, there was for CD4 cell count, approximately 1% of individuals had a cragemia that was asymptomatic. And then there was more recently another article that looked at 35,000 people worldwide, granted 2/3 of whom come from sub-Saharan Africa. And in that cohort, the prevalence of CRAG positivity in a CD4 count less than 100 was 6%, so slightly higher than that American cohort. So there's reason that we should be doing this or that we should think about doing this. I don't think that it's necessarily wrong to not be getting it either because, again, the recommendations state it may be considered. And so I just wanted to sort of pause at that point and see what people thought. I check it on everybody who has a CD4 cell count less than 100. I think how it's operationalized really depends. Sort of when I don't usually get it on the first lab visit because we don't really know if someone's CD4 count's less than 100, but it could actually change practice, right? If somebody has a CRAG that's positive, you're going to get an LP, and if they have cryptococcal meningitis, you would postpone ART. So it is a little bit hard to operationalize the practice of checking a CRAG. So there have been some settings where somebody has, let's say, comes in to establish care and I know that they've had HIV for a long time, then I'm maybe more inclined to just check a CRAG on that first visit. Or if they have temporal wasting or thrush or something else that might sort of suggest that they have AIDS, I may be more inclined to get that on the first visit. But it is a little bit tricky, and so I just thought we could talk about it. And thank you, Hillary and Brian, for sharing, but I think it's something that we should definitely consider. And then for the last I'll skip this question for now, it's just will it change your practice? The last thing that I wanted to ask is about G6PD deficiency screening. So in which individuals do you check a G6PD level? All people with HIV at entry to care, all people with HIV with a CD4 cell count less than 200, people with HIV with a CD4 cell count less than 200 who are starting dapsone for PCP prophylaxis, or people with a CD4 cell count less than 200 who you're starting dapsone in and who have a predisposing racial or ethnic background. Okay, so here it says that 58% of individuals are checking it in a CD4 count cell less than 200 who are starting dapsone, and 35% of people are checking it if that person has a predisposing racial or ethnic background. I'm going to close this and show you what the guidelines recommend. They recommend screening for G6PD deficiency before starting therapy with any oxidant drugs, such as dapsone, primaquine, or sulfonamides, in patients with a predisposing racial or ethnic background. Now, my practice is a little bit different than the guidelines. I think it's okay to go off of the guidelines so long as you know what the guidelines say and why you're going off the guidelines. And it's interestingly because the ABIM, or the American Board of Internal Medicine, in their Choosing Wisely campaign actually also recommends this, but I just check it with about 58% of the group here as well, who checks a G6PD level before starting anybody on dapsone. My practice is also a little bit different in that if I'm starting somebody on Bactrim for PCP prophylaxis, I will check a G6PD level, not before they start the Bactrim, but because I want to know if they get into trouble with the Bactrim, can I quickly switch them to dapsone? I know that there's not much importance in quickly switching somebody on prophylaxis because really prophylaxis is to prevent something over time, but that's just how I do it. And it's oftentimes helpful, let's say if this person gets admitted with PCP and you need to start clindaprimiquine, it's helpful to know what the G6PD level is. So I'm thinking about people who might be hospitalized as well. So that's that. Again, we don't necessarily need to reflect out loud, but I wanted to know if people will be changing their practice based on these recommendations. And again, wanted to sort of open it up because we're at the end of time and see what people think about this.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.